People with DID have a strong sense of self, but it's fragmented. There's no more or less sense of self than what you have, what I have now. This is not a conscious decision. It's not role playing. It's not play acting. It's really an unconscious adaptation that helps the child psychologically survive. No one should have to feel shame about having a psychiatric condition or having DID.
Hello and welcome to Being Well. I'm Forrest, Hanson. If you're new to the show, thanks for joining us today. And if you've listened before, welcome back. Today, we're going to be talking about dissociation in general and dissociative identity disorder, or DID in particular. Most of what people know about DID comes from movies and short videos on social media. And DID was once known as multiple personality disorder, which means that depictions of it often portray a person quickly switching between sharply different personalities. And in movies, this moment is usually played up either for drama or sometimes for horror. And they also have very little to do with what DID is actually like. Today, I'm joined by two very special guests who are going to help us learn what dissociation is, from the everyday versions of it that most people have experienced, all the way up to the clinical end, the relationship between DID and childhood trauma, how our understanding of it has changed over time, and hey, maybe the most important part here, what people can actually do about all of this. So I'm joined by Dr. Milissa Kaufman, a trauma psychiatrist at McLean Hospital and associate professor of psychiatry at Harvard Medical School. So Dr. Kaufman, Milissa, thanks for joining me. How are you?
Thank you. Good to be here.
I'm also joined by Dr. Lauren Lebois, a cognitive neuroscientist and an assistant professor of psychiatry at Harvard Medical School. So Lauren, thanks for being here. How are you doing?
Great. Thank you so much for having us, Forrest.
Really excited to do this with you guys. I learned so much when I was preparing for this conversation. I did not know how little I knew. And it was just such an interesting topic. So to let you know a little bit more about them, Dr. Kaufman founded the Dissociative Disorders and Trauma Research Program at McLean, and she and Dr. Lebois co-direct that program. Lauren is also former chair of the scientific committee for the International Society for the Study of Trauma and Dissociation. And along with her clinical and research work, Milissa had DID herself, went through treatment, and made a full recovery. And I wanted to start by asking Milissa, if you're comfortable talking about it, what is DID like? And particularly, how did your experience with DID differ from some of the portrayals of it that people are familiar with?
To begin with, as far back as I can remember, I had this internal sense of having what I called inside people, this sort of gang of kids that felt to me that lived inside my mind. And I really didn't think much about it. It just, had been with me since the time I can remember, certainly some of my first memories. And as I got a little bit older, I started to realize that people around me didn't talk about having people living inside their mind. And as I got a little bit older, there started to be this sense of a lot of conflict inside my mind. I didn't want to have these inside kids in my mind. I didn't understand it. The stories that they sort of discussed, if you will, became more frightening. There was a part that I pictured inside that of a little girl who lived inside a box that none of the other people wanted to be around, a lot of arguing. And it felt very real to me. As I got older, I started to think like, well, this isn't really possible. Why is this happening? And I became really aware of being symptomatic with it. Sometimes, and I didn't know at the time, but I was sort of having very dissociative like flashbacks where, I wasn't really aware of what would trigger, but something would trigger me and it would feel like I was experiencing the feelings in my mind of what it felt like were the inside kids. So if I got triggered, it would feel like an inside person would sort of come into my mind and I would feel their fear or I would see, you know, hear very frightening things. And then it would stop and I would think like, where did that come from? So it really was like sort of having flashbacks, but at the time it felt very much like sort of not me. That wasn't me. That was someone else, even though I knew that that wasn't really possible. So I grew up being very puzzled with myself, confused, concealing things. It was very hard.
Are there particular differences between the way that DID looks when it's shown in media and your experience that you would like to kind of call out here?
Yeah, there is. DID tends to be a hidden disorder. It's sort of famously, someone called it a disorder of hiddenness. And it really is. It's very alive and intense internally, but most people, you don't see these sort of dramatic switches unless someone is highly stressed, triggered in some way, really having a lot of post-traumatic symptoms. And in that way, it can look like, we've all seen movies probably of, Vietnam War combat veterans who come back and they hear a cloud, thunder or the backfire of a
Firecracker,
tire.
yeah, that kind of
Right,
thing.
exactly. And they hit the floor, right? And they're literally reliving what's happening. And that can happen, and it does, there are flashback-like moments, and again, as I said, what the difference there is that it is a flashback, but then there's this sense of it not belonging to self. A movie that I think about is Sybil. I don't know if you're familiar with that. It was a best-selling novel, and then there was a movie made about it starring Sally Fields. She won an Emmy for it. It was very affecting, but what it showed was her switching into people that had different accents, spoke with different accents, had different wardrobes. It was a very externalizing sort of manifestation of what was going on inside. And I think that that was the intent of the writer, was to show what was happening internally. But I, you know, I don't see that. I've never, worked with
Mm,
someone that, was, sort of dramatic in that way. And again, there can be a lot of shame, misplaced shame for sure, but it typically doesn't, people don't really want to show it. That's been my experience clinically. And
yeah.
there's been studies about it, where about 95% of people are sort of subtle and internal, and about 5% of people have a more overt, outer and maybe more dramatic, presentation.
So backing up a little bit, I would love to connect that kind of experience that you're describing here to the more mild versions of dissociation that most people have experienced, maybe even without realizing it. So, Lauren, I would love if you could kind of get into here with us. What is dissociation? And maybe you can lay out a kind of spectrum from those more mild experiences all the way up to clinical forms of dissociation.
Yeah, that's a great question, Forrest. I was smiling to myself because I feel like dissociation is a little hard to define because it can encompass so many disparate experiences. But I think at its core, it's a when the typical experience of consciousness is disrupted in some way. I think that's a good catch-all definition. And it can, but like I said, it can manifest in so many different ways. So, like you're saying, a more typical experience of it might be, I think that a classic example is highway hypnosis, where you get in the car and you drive somewhere, and you get there and you realize you weren't really paying attention. You were so absorbed in some other thought that you aren't aware of like the steps that you took to get to that destination. You're maybe moving a little more extreme on the spectrum would be experiences of depersonalization or derealization, which are a sense of detachment from your surroundings. So that's derealization. And that can look like kind of that feeling like you're in a movie, or things are a little surreal, or like you're walking through a watercolor painting or something. And then depersonalization, more of a sense of detachment from your body or your sense of self. That could be like observing yourself from above. Something that unifies those is that someone has lost a sense of agency and ownership over their own thoughts, feelings, emotions, aspects of memory, aspects of their sense of body, sense of self. So it feels like their own thoughts, feelings, et cetera, are not their own. Somehow they belong to someone else. though of course that doesn't quite make sense. Like we know that that's not possible, but that's just how it feels.
Yeah, and it is. It's a hard word to describe. There's many ways to define it. I think exactly what you said. There's this discontinuity, and the discontinuity is sort of an integration. It could be of anything. It could be a discontinuity in perception, which would be depersonalization, derealization. A discontinuity in memory, which would be amnesia or gaps in recall. A discontinuity in attention, which is that highway hypnosis kind of example. So you could have a discontinuity in motor control. So uh, sort of feeling as though you're moving in some way, or sensation, feeling in some way that you can't quite relate to. It's not really integrated. And what's fascinating about all this is that there are neurobiological indices that help us to explain why these things are happening.
What's layered on top of dissociation to get to a DID diagnosis or to get to the kind of experience that you were having, Melissa?
So I would say that DID sits atop the foundation of complex PTSD, or sometimes we would call it the dissociative subtype of PTSD. So all of the same symptoms and signs of a classic sort of PTSD presentation, such as intrusions, flashbacks, uh, avoidance of trauma reminders, negative alterations in mood and cognitions, and hyperarousal, such as startle, all those types of symptoms that people tend to be more familiar with. And then on top of that, in moving from sort of a conventional PTSD to the dissociative subtype of PTSD, you then have very severe symptoms of depersonalization and derealization. And then to arrive at a diagnosis of DID, you have two additional diagnostic factors. One is gaps in awareness or amnesia for day-to-day events, as well as past events, traumatic events. And then you have what's called identity alteration, which is sort of how I described. It's this sense of your thoughts, your feelings, your memories somehow not fully belonging to you, or completely, there's this felt sense of a lack of agency in terms of what is happening in your mind.
There's this metaphor that Sachi Nakajima uses. She's a survivor and an advocate and speaker and author. But she describes kind of the symptoms of classic PTSD, or like you're riding a roller coaster that you can't get off. And then if you have the dissociative subtype of PTSD, you're mentally able to mentally take yourself off the roller coaster, get a little bit of distance from those symptoms in a way, and watch yourself on the roller coaster while you're sitting on the ground. And then DID on top of that is you're able to take yourself off the roller coaster on the ground and watch, but now you're watching someone else on the roller coaster, or it feels that way. But I really love her way of describing that.
I think that's a great description. And I'm wondering, and I think that that description actually partially answers this question, which is how is DID an adaptation to the kinds of childhood experiences that you guys have? I've both heard you name as a prerequisite for this condition.
It really is an adaptation, and DID starts in early childhood. It's a post-traumatic. It's like a developmental post-traumatic adaptation. And what I mean by developmental is that it universally begins in early childhood. And it begins in early childhood when a child is exposed to severe and prolonged abuse and neglect. But to be precise here, and something that may surprise people, is that trauma alone doesn't actually cause DID. It's necessary but not sufficient. There has to be a biological capacity to dissociate and to compartmentalize experience. And lots of people have this biological capacity. It's kind of a normal distribution. But at the tail end, there's this sort of heightened capacity. And so it's a child who has a heightened capacity to dissociate, and then has very, very difficult, challenging issues during early childhood, and it becomes sort of a primary psychological defense. Little children have this natural capacity to displace and externalize thoughts and feelings. And little children also have a natural capacity to personify their thoughts and feelings. And to give you an example of that, you can think of a small child who's the first day of kindergarten, and their mom is telling them, they need to get dressed, get going, they need to go to school, and you can imagine a child saying, my stuffed animal feels hates you, but not me, something like that. So, or another child might say, I'm not scared. I'm not a little baby. I'm big and strong like Superman. So, what they're doing there is sort of displacing and personifying their thoughts and feelings that in the moment feel conflicted. And that's a very natural developmental way of handling sort of relational conflict in that way. And that's important to understand that this is a normal developmental way that some children uh, sort of deal with things that are hard to deal with. And it's not role playing because children at that age don't know that they're not going to grow up one day to be as big and strong as Superman, right? Children believe in Santa Claus. So keeping that in mind, imagine another little child who is being dealing with kind of desperate conflicts, is being abused, and neglected. And you can imagine a child who thinks to themselves, it's too frightening to feel that fear. That's not me. It's too overwhelming to feel such anger. That's not me. It's too frightening to feel what's going on inside of my body. That's not me. So, this too is a very adaptive way, and at the time, developmentally pretty normal way of dealing with extreme conflict. And that's where DID comes from. And it really is on some level that simple.
Hmm.
And if it keeps being repeated over and over again um, for many years, it really gets cemented into the way that a child deals with enormous stress and interpersonal conflict. And the conflict can be, you know, that I'm not a bad little girl. My daddy doesn't hate me. That's not me. Or, you know, I'm not, this, is not happening to me. Some little girls may imagine a boy who's big and strong and may imagine that sexual abuse might not happen to a boy. And it just, whatever the child sort of needs happens. And it's not conscious. That's a really important thing. This is not a conscious decision. It's not role playing. It's not play acting. It's really an unconscious adaptation that helps the child psychologically survive.
I'm really curious what that's actually like, to the extent that you're comfortable talking about it. Are these distinct, it comes from the earlier language, but essentially do these feel like distinct characters or, distinct
Mm.
personalities, whatever term you want to use here? When two of these self states are both going on in the same time, is it like a conversation inside of the head between two people you know? What's that actually like?
I really want to try to convey that. I will say, I gave a sort of example of my internal experience when I was growing up, and it's important to say that everyone is different. And, I had my own experience. I've talked to many, many people who describe these types of experiences, and no one has the same exact experience. But having said that, it can, a lot of people have described having this sort of sense of an internal, their mind is like, in some ways, kind of like technicolor, and their mind has dimensionality to it. And it can be like watching sort of other people who are familiar and have been with you for a long time, but you don't know why they're there. You don't want them there a lot of the time. It's weird and strange. Some people really don't have that internal experience it so vividly early on. It's only sort of later when they sort of become more aware of it. Um, yeah, it can feel like, I mean, if you can imagine, you might have had this experience, Forrest, where you're debating, I don't know what you might be debating. What was the last thing you kind of debated in your own mind?
Totally know what you're talking about. Yeah. Anything ranging from where am I going to go to get dinner to how
Yeah,
do I feel about a particular topic. You can have this
yeah,
feeling. And for me, it all sounds like me. It all sounds very Forrest, and I'm just kind of
yep,
operating in these different perspectives. But it's
yeah,
absolutely a voice inside. For me, I get like internal vocalizations, like I hear my voice inside of my mind, which I
yeah.
didn't even know that some people don't experience that at all.
Some people don't experience that at all. You're exactly right. So everyone's different, but this is a sort of capacity that you have to sort of immerse yourself internally and kind of hear, if you will, your own voice. I don't know if you visualize yourself going back and forth, but again, that's a natural capacity. And I think that people with DID, I don't think it, I know it, are really on that far end. And so it is. It's like hearing your own thoughts, but it feels like someone else. And because it's so personified, and people with DID have this intense ability to kind of absorb, and it's often accompanied by you can see this other sense of self. You can, I saw, as I told you, sort of a little girl in a box. And it never changed. It was always a little girl in the box, nothing, and it was, to me, it was, I'm not a very artistic person, and, I'm not a very spatial person, but it was really kind of like a stick figure, but a sort of little 3D stick figure in a box,
Hmm.
and I saw, a little boy who was angry all the time, and would sort of hear, but not the way that you're hearing me. There is a difference. I didn't hear it externally, but it was like hearing your own thoughts, but it didn't feel like my own thoughts. It felt like someone else's thoughts. And I would visualize. I mean, again, it wasn't conscious. I would see them inside my mind. And it was
Hmm.
always the same kids, and very relational. They had these stories about being angry, or stories about being frightened, or stories about being smart and able to go to school when I didn't feel so smart.
Hmm.
Those kinds of things.
So, given how vivid these self states are, what's the problem with the phrase multiple personality disorder? Why did we kind of move away from that as a phrase?
Yeah, that's a great question, Forrest. I think the problem there is that to name them personalities in some way reifies them as real, full blown inside like different personalities, whereas using the term self states or dissociative self states makes it a little more clear, both for scientists and clinicians talking about this, but also matching the lived experience of, well, it may feel that way that these are inside people. They actually aren't. There's just one person, one brain, one mind, and their own, as Melissa's been saying, your own conflicted thoughts and feelings come alive in this technicolor internal landscape. So I think that's at the crux of it. And I feel like that's very important, not to reify them in that way, which of course it's so hard to do because it something that maybe distinguishes DID from other conditions is that there is this intact reality testing where someone is aware that, as you've just said, Melissa, in the when you're describing these things of like, oh, I know this isn't possible. This is just kind of how it feels, as opposed to being lost in the belief that this is this, I don't know, as you might see in psychosis, where, oh, I really am hearing that voice from the radio. I am getting messages from this famous person.
Raise your hand if you've been putting off a dental cleaning, an annual checkup, or honestly, any kind of doctor's appointment. Yeah, my hand's up too. When something feels off, it's easy to avoid the problem, maybe by doom scrolling through TikTok, venting to friends, resorting to AI advice. I wouldn't recommend that one, or just saying it'll probably get better, right? If that sounds familiar, it might be time to do things a little differently, like finding a real doctor through our sponsor, Zocdoc. Zocdoc is a free app and website that helps you find and book high quality in network doctors so you can find somebody you love. Whether you're looking for dermatology, dentistry, primary care, or urgent care, you can find in network appointments with more than 150,000 providers across all 50 states. When you're ready, you can see their real time availability and click to book instantly. And while you're on Zocdoc, you can view thousands of verified patient reviews. I think those reviews are one of the best parts of the site. Stop putting off those doctor's appointments and go to Zocdoc.com/beingwell to find and instantly book a doctor you love today. That's ZocDoc.com/beingwell, Zocdoc.com/beingwell. Thanks, Zocdoc, for sponsoring this message. I'm curious about the real, not real part of this, Milissa. What I mean is, you said a little while ago, toward the beginning of our conversation here, that you kind of knew that this was not the way that most people were relating to their internal experience.
Mhm.
But there is something in it that is so vivid and so real and so engrossing. Like the way that you're describing these different self states, the imagery you're using. How did you reconcile that internally? Were you just like, there's something deeply wrong with me? Did you, I mean, what was your frame on it?
I was so baffled. Um, and again, there was this real press not to tell. And I think part of that is, I didn't want anyone to think I was crazy. But also the things that sort of I was experiencing internally um, were frightening and scary and reminiscent of things I didn't want to think about. One way to really think about what dissociation is in this context is sort of this ability to know and not know simultaneously. And that's exactly the experience. You know, but you can't know. Yet you know, but you can't know these things. And it sort of manifests as I can't know that I have these people inside, even though it feels so real. I can't know that. But what's behind that is, other reasons, other things that you can't know. Why can't you know
Mm,
about the, internal people, the inside people, what I talk about? Well, because I don't want to know what their stories mean. They're holding tremendous conflict. If there was no conflict, there would be no DID, and you don't want to know, and yet you can't help but realize, like, this is happening. It was part of my day to day life.
mm.
So, yeah, it's a real, it's perplexing, very perplexing. Didn't want to tell anyone.
Yeah, and I would, as you've already said, there could be an enormous amount of shame associated with this experience for somebody because there is that feeling of like deep differentness that is so tied to shame psycho-emotionally.
There's the shame of being different, and there's the shame that people that have been through child abuse and neglect, small children, have this way of feeling that it's their fault. And because, children, the world around, revolves around little children. And if someone is harming you, it must be your fault because, why would a parent who is supposed to love you love? And that's where the conflict arises. And it's also a form of mastery. If it's the child's fault in some way, then they can have some more control of it. So I've personally never met someone who it was abused as a young child or had DID who didn't have a lot of internal shame that again was sort of compartmentalized off. Um, which is not to say that I ever would think that someone with DID should have shame. And I bring that up because I think my discussions about shame sometimes have been misperceived by folks, and it's I would it's a very misplaced sense of shame, and no one should have to feel shame about having a psychiatric condition or having DID, but it is a very sort of natural thing that happens when you grow up like that.
One of the things that can contribute to this, and certainly doesn't help, is that there is a long history of skepticism toward the DID or multiple personality at the time diagnosis that I was actually completely unaware of before preparing for this conversation. And it goes all the way back to Freud and even predates that to some extent. Um, as an outsider to all of this, it also felt to me like some of the exaggerated presentations that we've seen of DID in the media probably contribute to that kind of skepticism because it's so over the top or disconnected from people's kind of lived experiences. And one of the things that has come along in a really cool way that has helped, I mean, obviously there's total credence to people's experience of DID, but has helped kind of like show people, hey, this is a thing, has been some of the brain science related to it. And so, Lauren, I wanted to ask you about that. You were talking about that roller coaster, classic PTSD, then this dissociative subtype of PTSD, then maybe all the way up to DID. And both out of my own curiosity and maybe to kind of like help people along with this, do these things look different in the brain? Like, is there a difference in a scan of somebody experiencing one versus the other, or somebody who doesn't have DID doing a sort of performance of DID versus somebody who actually does? Like, what does this all look like?
Yeah, those are great questions, Forrest. And there's a rich neuroscience of dissociation and DID. Our lab has done some of this work. Simone Reinders has done a lot of this work, and Ruth Lanius. And there are some. Yeah, I'm trying to think what would be the most helpful. I think there are three key kind of buckets of the foundational neuroscience of DID that might help clarify some of these things. Some of the work focuses on this type of paradigm called a symptom provocation paradigm, where they have folks come in, narrate personal traumatic events that they've had. Those recordings are played back to them while they're in a neuroimaging scanner, so you can in some way trigger someone and get what's happening in the brain while they're actively symptomatic, listening to these memories, these traumatic memories of the past. And when you look at what's happening for folks with classic PTSD, for our purposes today, we can focus on two regions in particular that come up time and time again. One being the amygdala, which is involved in lots of different functions, but most basically, we can think of as like a salience detector that's helping to alert us to things that would be important to pay attention to for our survival. One example of that is potential threats. There's also the ventromedial prefrontal cortex, which is, we can think of broadly as an executive controller, helping to regulate our physical and emotional reactions to things. So these two regions, they can communicate back and forth with one another. In classic PTSD, so folks without those more intense experiences of depersonalization and derealization, having more of those experiences of being emotionally flooded, hyper aroused. When they do the symptom provocation paradigm, on average, you'd see hyperactivation of the amygdala, helping them mount this full body stress response to deal with this potential threat in their environment, which of course is just listening to a recording of a memory from the past. But and then there's a deactivation of regions like the ventromedial prefrontal cortex, so it's not putting the brakes on that amygdala activity. And that matches what they're saying of their subjective experience, that they're emotionally flooded, on guard, hyper aroused. When you look at folks with a dissociative subtype doing the same paradigm, we actually see the opposite pattern, where there's increased activity in ventromedial prefrontal cortex, decreased activity in amygdala and other regions. So it's like the brakes are on too tightly. They're not mounting that full body stress response through the amygdala. And that matches what they say about feeling more numb and detached when they're triggered and dissociative. And then Simone Reinders has looked at folks with DID doing the same symptom provocation paradigm. And she has folks with DID listen to the trauma narrative twice, once in a self state that feels more of a sense of ownership over a trauma memory, has more of a subjective experience of being more hyper aroused, I would say. And then also in a state that is more numb and detached and has more distance from the trauma memory, feeling as if it didn't happen to them personally. And she sees that folks with DID oscillate between those two PTSD patterns that we just talked about, depending on what prototypical self state is active at any moment in time. So if they're
That's
in
really
more of a
interesting.
numb, detached state, oh, we see the brakes are on too tightly. Oh, if they're in more of a state that feels more hyper aroused, more of the re-experiencing of the trauma memory, that the brakes are off. You get that hyperactive amygdala activity. So I think I find that set of studies really helpful for placing DID on a
Painting a
continuum.
picture, yeah.
Yeah, with PTSD and the dissociative subtype.
Totally. And it helps people understand that experience.
Yes.
Yeah, and, like, that idea of the brakes being really on or, yeah, as opposed to the whole body activation that you were talking about really gets to the kind of experiences that people have with this, and I think can help us, like, have a little bit of insight into what this actually feels like. In terms of, you mentioned, Dr. Simone Reindeers and colleagues, and I thought that the simulation studies that I bumped into this were so interesting, where they basically had somebody who was acting out DID and somebody who was having, more genuine experiences, and the pattern of brain activity was really quite different between these two groups, which again just helps like lend credence to people's experiences, which it's a shame sometimes that people need that, but it's nice to have it.
Yeah, I completely agree, Forrest. Those are great studies. In fact, the majority of studies in DID have a simulator group and
That's really
Simone's
interesting.
studies, they do train them very well. Sometimes they're paid actors. They teach them a lot about DID to try and do exactly what I think some of the some alternate theories of what DID is, the role playing, the suggestion. They ask them to do those things, and then they compare them from someone who's genuinely diagnosed with DID, and in not one instance have they found that across dozens of studies have they found that the brain patterns are matched. So I do think that's great evidence to show that it's not a disorder of cultivated by the media or therapists, overzealous therapists, or this condition of role playing in some way. One other thing I will add though is I feel like it's a little bit of an unfair, like, I don't know, we don't ask folks with anorexia to have a anorexia simulator group, and then it feels kind of like an unfair thing that we have to do sometimes in the DID world, to spend money on very expensive imaging for folks who are just, we've asked to simulate this to show, but hopefully we're moving past that phase.
So I did want to ask you guys about something that gets to this a little bit, which is this idea of therapist suggestibility. My fiance Elizabeth is an associate therapist, and she focuses on trauma work. And she had a couple of clinical questions that I thought were really interesting, and one of them I just wanted to steal from her, so full credit to Elizabeth here. And they get to some of the past controversies in this space. Her experience is that in therapy, when she's asking about somebody's experience or has gotten to the point of developing safety in relationship that allows her to offer some kind of a perspective, there's often this healthy process of the client pushing back on what the therapist says, at least to some degree. Saying something like, that's not quite right, or that doesn't align with my experience, or whatever. And then there's this sort of healthy negotiation process. There are even people like Dr. Jacob Palm, who works with CPTSD and similar things, who talk about this process of rupture and repair as kind of like a critical part of the work. But that requires that the person who's in there with the therapist have a strong enough sense of who they are, what they care about, what they like, what they don't like. In other words, me, to feel comfortable kind of like pushing back on the clinician a little bit. And this made us wonder if people who are more dissociative in general, going all the way up to DID in particular, are more susceptible than the average population, to clinical influence. And if that's led to some of the pitfalls that people have experienced with this. And she also had just a practical question about, if so, how do you navigate that when you're working with somebody?
Yeah, I'm happy to take that question. I think so what you're talking about really is suggestibility. And what I can tell you is that folks with DID, highly dissociative folks, um, are not more suggestible than someone without a psychiatric control, and that's been a point that's been hotly debated, and maybe not so much anymore, but something was in the late '80s and '90s. There was a lot of sort of uproar about false memories. What is more related to severe dissociative symptoms? Is it trauma history, or is it this type of suggestibility? And what they found was that in all cases it was trauma history, and that folks with DID uh, in many cases were no more susceptible than anyone without a psychiatric condition, and surprisingly, we're actually less suggestible in
Hmm,
some way. There is something called hypnotic suggestion, and I
hmm,
think that these terms got somehow conflated early on. And what hypnotic suggestion is how susceptible someone is to going in and out of a trance state. And people with DID are highly susceptible to going in and out of trance
hmm,
states. That essentially is what's happening. If you're in a trance, you are going to have perceptual discontinuities. You're going to have sensation discontinuities. That's part of what hypnosis is, but it is very very different than memory suggestibility. So I think that's
hmm.
that's where things got confused. So does that answer your question?
It does, yeah.
Mhm.
I'm not sure about this because I'm not a clinician, so I'm vamping a little bit here, and I would love it if you guys guided me, however you think appropriate. I think that part of the experience that she is speaking to is in a clinical setting, working with somebody where there's not a really cohered, for lack of a better way of putting it, sense of self, sense of like total I that you're interacting with. People sometimes will use like parts language related to this. IFS has become enormously popular. Parts work has become a phrase that a lot of people use these days. And it's sort of easy to start conflating these terms, self states with parts, with I'm sure other terms that people have for this language. And so I think that she's talking a little bit about the practical work when you're, as a associate trauma therapist with people who um, have more of a sense of these different parts or feel like there isn't as much as they'll use in that kind of language tradition, self energy, or whatever term you want to use for that kind of a thing that's involved, and how to support that person essentially, um, including in like that natural process of, hey, I like apples, not carrots, that you're kind of doing clinically sometimes with people. So that's where I think some of the question is coming from. But I would also love you guys to kind of peel apart, yeah, the parts thing. Like, are these parts? Are they something different? How would you like to clarify the language here?
People with DID are one person who have a singular mind who subjectively at times have these experiences, these not me experiences. Um, and that means that the sense of self is less subjectively felt as cohesive, but it's I wouldn't want someone to fall into the trap of thinking that there's not a developed sense of self in someone with DID. It's a
Yeah.
subjective feeling. And sometimes, given the language, we can fall into like, oh, they must not have a sense of self. People with DID have a strong sense of self, but it's fragmented, if that makes sense.
Yeah.
And
Totally.
so it's not like there's nothing there. There's no real person. It is a subjective self, a sense of self. It's a compartmentalization, but there's no more or less sense of self than what you have, what Lauren has, what I have now. So it can be sort of the language can be misleading. So that's sort of important to point out.
Great. Yeah. No, I appreciate that.
And in terms of, thinking about IFS, I'm not an IFS expert, but, please correct me if I'm wrong, but my sense of it is that you have someone come in and, uh, they have a sort of very cohesive feeling, sense of self, and there's a sort of relaxation into uh, feeling the sort of sense of internal multiplicity that, we all have self states. You, Forrest, are, you're a boyfriend to someone, you're a son to someone, you're a podcaster to millions of people, and you may act a little differently or feel a little differently, right? In these kinds of scenarios, you're probably very different, when you're out to eat with, your friends and you are here on the podcast, and that's just self states. And so I think there's this, again, correct me if I'm wrong, but sort of this relaxation into this sort of sense of having multiple sort of senses, ways of being in your mind, and then in IFS, it sort of gets grouped into what I'm recalling as sort of managers, protectors, uh, firefighters, if you will, and the exiles, which may be the sort of scared and frightened parts that we all have. Um, but it's really not as compartmentalized as folks with DID, and it's also there are no amnestic barriers. Um, and so there's just sort of letting go into this where with DID, the whole point of treatment is to, from day one, begin to help a person gradually over a long period of time to begin to move from a sense of not me to, "Oh my god, that's me. No, it can't be me. It's me, but it's not me," to like, "Oh, wow, that was me all along." And that takes a lot of time. It takes a lot of working through what the tremendous, sort of desperate conflicts are. But over time, someone with DID becomes more able to face those things. And with that, there's a shift from "that's not me" to like, "My god, that was me all along," because they're sort of done dealing with the, very difficult thoughts and feelings and experiences and memories that they have, and are strong enough. And I say strong when people with DID are strong, but are emotionally have this capacity then to own what could not be owned.
So I would love to turn more toward the what to do about this piece that you're already talking about here. What does therapy for DID look like, or maybe therapy for dissociative symptoms more broadly?
I think most basically because DID, the relationships, the interpersonal relationships were the problem, therefore they are the solution in treatment. And so I think Melissa and I are on the same page of relational psychodynamic therapeutic approach is the gold standard treatment for DID. And the International Society for the Study of Trauma and Dissociation has expert consensus guidelines that, much like there's a phased treatment to PTSD, there's also one to DID, where phase one is, and Melissa, I'm sure you can add a lot of color to this, but focused on stabilization, building safety, building a language together, learning to regulate emotion with maybe a little more awareness or less reliance on dissociation, being able to ground, practicing those skills either very overtly and explicitly or kind of as things are coming up in conversation. Phase two moves into more of trauma processing, actually, yeah, more getting into the traumatic memories. Phase three is more into integration, building a life without using the dissociative defense to cope with the stressors that come up in all of our lives. And I think maybe an important thing to emphasize is that I've made it sound very linear, and of course it is not. It's a very fluid, coming back, going forward, coming, like working all these things at once as well.
Yeah, I'm really curious. Were there particular things that you did or things that stood out as part of the process to you?
In terms of having gone through that treatment myself or
Yeah.
being a treater. I mean, it's all sort of wrapped up.
God, I think
Um,
both either. I think they flow together at some point here.
I agree that it is, it's good to think about it in terms of phases. Uh, One thing to think about is that, folks with DID have PTSD and, they're starting to process trauma from day one of treatment. And the memories, the thoughts, and the feelings, it's there. It's a part of their life. So what can be really helpful in stage one is to learn how to manage those feelings, as long as talking about grounding even before you begin to ground, to recognize when you're starting to dissociate. And that's a really important thing that trauma therapists do, is to notice and say out loud, what's going on. You look a little foggy, or where are you? And that's often the first time that someone has ever said to someone, like, what's going on here? And over time, with the treater noticing things, the patient will begin to notice as well. And that's the first step towards sort of taking agency over your own symptoms. And along with that, which I think is really important, is that during this stage, um, it's very important for a treater to help the patient understand and titrate out trauma. So, for example, if someone starts to, talk about a traumatic memory, the therapist and looks distressed. The therapist might say, you're looking kind of distressed. Um, you have the choice about whether you want to talk about this right now or later. And over time, that begins to sink in, and there begins to, first the therapist is sort of modeling that over and over and over again. You don't have to talk about this right now. You can, but you don't have to. And if you don't want to, I'll work with you to develop the skills to sort of deal with the symptoms that you're having. And gradually over time, there is this development of a sense of control. I don't have to talk about this if I don't want to. I can talk about it, but I don't have to. And I can't really stress how giving, modeling and giving the person back this sense of control over their own mind. Um, I can't, I don't know how to say how important that is. Very important. And, starts in phase one, but continues on throughout. It's not really as phasic as is on paper, but that's really important.
Before we get back to the show, I wanted to quickly let you know that we want to know more about you. So you can go to rickhanson.com/survey and fill out our Being Well podcast audience survey. We want to hear about the kinds of topics that you're interested in, when and where you listen to the show, the kinds of advertisers that you would like to hear us talk about in the future or have some kind of offer related to. It would really help us out to learn a little bit more about our listeners. So again, that's rickhanson.com/survey. The survey should just take you a couple of minutes. It really helps us out. So I've heard you both mention trauma-informed treatment in different interviews you've given and conversations, and you both really emphasize the importance of trauma-informed treatment, particularly for something like DID. That term has become very popular, and people will use the phrase trauma-informed on any number of social media posts having to do with all manner of things. Is this a codified approach to therapy? Is it an adjective that's applied to different kinds of therapies? What makes something trauma informed?
I'm glad that you asked that, because for noble reasons, everyone wants to be trauma informed these days, and that's really important. But through that, I think that the word itself, sort of trauma informed practices, has become somewhat diluted, and can mean many different kinds of things. And that's actually something that the Department of Health and Human Services actually commissioned a document where a number of us got together and really started talking about, what does it actually mean? How do we measure it? How do we define it? How do we know it's working? Um, but I can, sort of, I guess, boil it down how I think about it, just my own self in terms of trauma related practices, which is very different actually than, trauma related treatment. But practices start with something simple, and that is recognizing that, there's a high prevalence, um, you know, experiences of traumatic stress are pretty prevalent. So you recognize it, and then when a patient comes in to seek treatment, you ask about it. So recognize it and ask about it before the patient has to try to discuss something that's very different. You ask about it. Secondly, you recognize that sort of problem behaviors, such as dissociation, uh, avoidance, aggression at times, substance use, things that are typically seen as problem behaviors. If in someone who has a trauma history, there's good reason for it, and so understanding and looking through the trauma related lens at these kinds of behaviors. I guess also really understanding that there's a power differential. And for people who have been traumatized, power and control is with them all the time. It's something that you really need to be careful of and reflective about in your interactions with people who have been traumatized. This is really important at the individual level, but the most meaningful way to make change is at the structural level, at the institutional level. And that can be hard to do. It's more than being kind. It's more than attending an annual training on what is trauma informed care. I'm glad to hear that at the highest level at the Department of Health and Human Services, they're looking into that. I think that's really important.
Just in the realm of treatment, I did want to call out, there is now a standardized, empirically based, manualized form of phase one called Finding Solid Ground. And Bethany Brand, Ruth Lanius, and Huga Shilka have developed this. They recently finished a randomized control trial that has beautiful results. And so this has done, it's very exciting in the field because once you have something that's a little more standardized, it's easier to research it and get funding to research it more broadly than what they've already done. And this is the first time we've been able to do this in the field, to study treatment in this way, in this particular way. So I know Milissa and I are really excited about this, and I just wanted to shout out to them.
It's really a landmark.
Yeah, that's great to hear about. And I'm trying to wrap my hands around something that I'm not quite sure how to talk about. And this is a little bit more vampy. I'm curious what your
Yeah,
feelings about it
go
are.
for it.
Where it feels like y'all are as serious as it gets with this stuff, for lack of a better way of putting it. You work with a serious hospital, serious institutions doing very, very serious academic work. And there's also something about the way that trauma is becoming talked about in very, very serious places that sounds just vibe-wise much softer and fuzzier than some of the very manualized approaches that I kind of will hear people talk about, more kind of CBT top-down approaches. Just the title, like Finding Solid Ground, as a approach to therapy that we're then going and testing and doing like these great investigative studies on. And so there's this kind of like funny convergence that's happening maybe between the more academic side of the coin and the more practice driven or like humanistic side of the coin. I'm not even quite sure how to talk about this because I'm not deep enough into the weeds. But as I'm just kind of talking about this, I'm curious what you guys are thinking about what I'm saying.
Let me try to unpack this. So I think
Sure.
I understand what you're saying. So yeah, we're talking about these empirically validated treatment studies. We're talking about publications. We're talking about grant funding. These are all very serious things. What we're not talking about are the, really important types of treatment that may not have some sort of gigantic clinical trial, but a lot of patients really find a great use from. And this can be body oriented treatments. This can be yoga, trauma informed yoga. This can be IFS. This can be, all sorts of modalities that are, we're not talking about in terms of these gigantic clinical trials, that sort of thing. Is that what you mean?
Yes, I think a little bit. I think that even getting to something like the phrase trauma informed, when a phrase becomes popular, it gets used as signaling a lot by people. So I'm sure there are many, many clinicians out there who have the phrase trauma informed that appears somewhere on their website. Most of those clinicians probably have some formal training that leads them to use the phrase trauma informed. For some, it might be more vibes. I think that codification of these things is good on a lot of different levels. Um, but there are probably also plenty of people who don't necessarily use the phrase trauma informed, but they've got a good feel for phase based work. They've got good pacing. They're good at developing a relationship with the person. They kind of understand dissociative process. Okay, great. They're not using the term, but they could be a very good trauma informed clinician. So I don't know. I guess I'm
Absolutely.
just kind of dancing around some of the intrinsic fuzziness of this whole thing right now with where the field's at broadly and just like the reality of practice for people.
Trauma informed started off as, again, sort of something structural, something that would be mandated at the institutional level so that patients didn't get ignored, so patients didn't get pigeonholed as bad or, I don't know. It's been taken now to sort of an individual level that for, someone to practice individually as a trauma-informed treater, you have to take these courses, you have to fill out these fill out these forms. Uh, Good treatment starts with, things that, what makes a good psychotherapist? What helps patients? I don't think you need to have a plaque on your wall to say, "I am trauma informed." So yeah, I see what you're saying. It sort of has lost its meaning in some way and become this badge in a way. I think it's very important, but people who are sensitive, conduct good psychotherapy, have good boundaries, care about their patients, care about keeping up with the literature. I mean, that's all part of being a good treater. You don't need to have a plaque on your wall to say that you're trauma informed. Having said that, there are there have been people that practice in a way that's not trauma informed. There are institutions that are not aware, recognize that a lot of their patients have histories of trauma, and there's probably a different way that you should do your admissions process. There's probably a different way that you should, you know, organize things to just sort of help people to understand what it's like to walk in the world with these kind of trauma related issues. But is that sort of what you're getting at?
Totally, yeah. Yeah, no, for sure. And I think
Okay.
that some of it, what I'm feeling is that there's a softening of vibe, for lack of a better way of putting it, in terms of the way that some of these things are talked about at a very, very high, like, institutional level, that is more thematically similar to some of the warm and fuzzy, humanistic or approaches of the past. And so there's something there that I just found really interesting and lovely in how you guys were talking about it and how you're talking about this slow process and establishing that kind of relationship and learning how to tune in to yourself as a person and to the person you're working with as a clinician, which also means to some extent tuning into yourself because of the natural back and forth of it all, right? And I think this takes us maybe to some practical takeaways for people. Most people listening do not have DID, but almost everybody listening probably dissociates in some small way at some point, right? All the way up to more frequent and intense forms of dissociation. And I'm wondering what you think people who experience more mild or everyday forms of dissociation, including ones that are intrusive and frustrating for them, what they can take from what you've learned about working with DID, like the very far end of the spectrum.
I like that question. I never heard that before. I would say that understanding that dissociation is not a defect, dissociation is an adaptation. That's very, very important. There's nothing wrong with someone for dissociating. There's a reason that you're dissociating. There's a brain basis for why you're dissociating. It's not as mysterious as it might feel to you. It's not as mysterious to most clinicians. So I think that
Mm,
that's really important. I also think, kind of tagging along with what you're saying, Forrest, is uh, that the relationship is everything. Relational psychotherapy, humanistic psychotherapy, being a good therapist is really important for people who are dissociative, whether or not they have DID or if they have depersonalization, derealization disorder, if they are just incredibly absent-minded and they don't really know why. All sorts of different ways that dissociation can come up in a treatment. Uh, it helps. The relationship is of central importance, and finding someone who just practices good psychotherapy um, really is the best kind of help, I think. And this is a little off topic in some sense, but I think it's really important to note that severe dissociative disorders, like we're talking about, like DID. I mean, it'd be great if all therapists were trained in how to treat DID, but they're not. And it can be very hard to find a therapist who has specific training in DID. So does that mean that people with severe dissociative disorders can't be treated? It doesn't. You can be treated by someone who is a good relational psychotherapist who has very good boundaries, who is very consistent. And if they need consultation or to do some learning, it's out there. But you don't have to be a master clinician to treat this. And I think that's really important because I've heard a lot of clinicians say, like, "Oh, I can't take this person with DID. I won't be able to treat them." You can treat them. It's really like treating anything else.
I also wanted to ask at some point here, what does recovery look like? What does it mean to be recovered from DID or severe dissociative states in general?
Maybe to start off, it would be good to separate recovery from the related but adjacent concept of someone's like healing journey. So I think more basically in this context, recovery is from DID is not having dissociative self states anymore. It's having a sense of agency and ownership over your feelings, thoughts, memories, um, and being able to trust yourself enough to allow that. Um, but again, to separate it from someone's healing journey, and there are they for someone with DID who gets to a point of more awareness of having states, dissociative self states, more cooperation, more of a sense of fluidity or ease, but still having the experience, an internal experience of dissociative self states, that could be a great place for them to land in their healing journey. And I guess I just wouldn't call that recovery from DID because they would technically still have DID, but that may be what healing looks like for them. Um, yeah. And I guess I also want to be careful not to, I feel like we're walking a careful line of like, I don't want to imply that there's like a better place to land in someone's healing journey. I would never tell someone they have to get to a certain place. And at the same time, if someone is in that place of still having dissociative self states, wondering about what might be underneath of it. What fear is there of letting go, of having that experience? And something that does come up that Melissa and I have talked about with some research participants, or in the context of groups of folks with lived experiences, a fear of losing an aspect of self, that it would be gone, which I think, of course, demonstrates part of the symptomatology of DID, because in reality, of course, it is all them. You won't lose an aspect of self. You'll just have a sense that it's you, but that does come up a lot. And so I guess that I feel curious about, if someone is saying they don't want to move past that place, what are the reasons why? And could they enter into those spaces with some curiosity as well?
Hmm.
Yeah. Melissa, what would you add to that?
That was well put. Nothing. I think you did a great job with that.
I did want to ask you, Melissa, if you're comfortable talking about it, because it's a little bit gets to some of, I think, what Lauren was saying about concerns over losing these self states, losing an aspect or of perceived identity is maybe a way I would describe it. I don't know if that's quite right, but that's the language I would use. For lack of a better way of putting it, what was that like for you? Was that a concern that you had?
Yeah, for me, it was a very gradual progression.
Mm.
Um, I went from having this sense of having these aspects of self that I didn't understand why they were there. I couldn't control them. Um, to again this sort of like, okay, it is me. But it's not me. Sort of. And then gradually over time, arriving at this point where like, my God, that was me. But like sort of right before I got to like, this is all me. Um, I did have this sense when I became much more sort of conscious, that these different aspects of self were because I held conflict. I was conflicted about things, and once you can sort of understand this is me having being very conflicted about difficult things that have happened, you almost don't have DID anymore. And as I was sort of at that phase, I got worried because I had aspects of self that I realized. Um, I mean, this is it's sort of I don't know if it's a silly example, but um, whenever I had to speak publicly during school, there was this sense of self that I called the nice lady, who was very It felt like she was very composed, and it would just sort of happen when I publicly speak, and there's reasons that I was very conflicted about public speaking. A lot of people are pretty phobic of it. I'm phobic of it, and I really don't like people sort of. I don't like the experience of people looking at me, or I didn't. That was very conflicted for me. So I had the nice lady who, always seemed to sort of come out when I had to speak publicly. And as I was getting better, I realized, my God, someone had, called me to do some sort of talk. And I was like, how am I going to give this talk if the nice lady goes away?
Mm.
And I also was sort of aware that, the nice lady is me, but she also feels like not me. What's going to happen? Um, and as it turns out, I no longer feel that I have a nice lady inside. I still really don't like to speak publicly, and really being on your show, Forrest, just so you know, don't love it. Having to speak like this, but there is this sense of a loss. I think for some people,
Mm.
not for some people, there is in the end, your sort of compartmentalized self states are protecting you. And
Yeah.
as you begin to sort of understand that and understand the sort of perceived roles, there is this fear like they're going to go away. How will I cope? And that was the original conflict, right? It's a child who does not know how to cope. And the conflict becomes conscious. But before it really becomes all you. You do have this thought of like, "Oh, are all these people gonna go away? How will I
Mm,
get on with life?" And so it's a very natural place to find yourself in the progression.
mm.
I hope that that makes sense. It's hard to put into words, but I hope that makes sense.
Makes makes total sense. Yeah, absolutely. And very understandable that a person would feel that way.
I think it makes interesting evolutionary sense as well, just from a standpoint of as humans, I feel like we're supposed to be with other people and in relation with other people. And as a child going through this experience and you're alone with it because the person who's supposed to take care of you is doing this to you. I don't know. I've been thinking about that a lot lately of like, wait, this makes evolutionary sense that you unconsciously would cultivate people to be with to help you with this inside your own mind. I think I don't know. We haven't really talked about that a lot, but I feel like that makes a lot of sense.
I think you're very, very right, Lauren, in the end. Uh, and that's getting back to your question, it's an adaptation. It's not a defect. It's not, it is something that really serves the child well. It becomes, very difficult as one gets older and living with the idea I wouldn't really wish upon anyone, but it is an adaptation. It is protected. It's how a child survives. So I think you're right. And what do children know? Children know their parents, their friends, other people. So it is of no surprise that they're personifying aspects of self to help them get by.
Well, this has been completely fascinating for me, and I need to get you guys out of here. Otherwise, I would, hold you hostage and ask you about a dozen other questions about this. But I feel like I've learned so much about it already. It's been so interesting to hear you talk about it, and I really appreciate both of you. And Melissa, also really appreciate your transparency and openness here about your own experience and your willingness to talk about it in this kind of way. I think that's part of what makes your work and your influence here very unique in that you can wear, both of the hats. You can wear the clinician hat, you can wear the researcher hat, and you can wear the person who's experiencing this hat. And it really helps people understand and translate it to a broader group. So I just really appreciate it.
Thanks, Forrest. I do want to say that it's not easy in some ways to sort of feel this vulnerable. It feels at times it still feels a bit risky to do this, but I am an admirer of your show. I've seen other guests who I admire speak in this way, and it did give me a sense that this would be a good place to talk about these things in the service, not so much of autobiography or you know, I'm not special. Nothing that I'm describing is special or unique. A lot of people, have these kinds of experiences, but it does feel risky. And there's something about the way that you interview people and how, I don't know, how respectful you are that made me feel like it was okay to do this. So thank you.
Thank you. That's really very genuinely touching. I truly appreciate that, Melissa. And Lauren, thanks so much for joining us as well. Like you've really added a lot of great color here for the cognitive neuroscience of it.
Oh, thank you, Forrest. And I just want to reiterate what Melissa said as great admirer of your work on here and their ability to translate for the broader audience to because I feel like that's so much of what the barriers to helping folks is that the information isn't translated, it's not accessible, and just so grateful for your work in this space.
Thank you. And it honestly really means a lot to me. And again, thanks so much for the time, both of you. I really enjoyed today's conversation with Dr. Lauren Lebois and Dr. Milissa Kaufman about dissociative identity disorder, or DID. Once known as multiple personality disorder, DID is characterized by a combination of severe forms of dissociation. So, this could include depersonalization, where a person feels detached from their self, their body, their thoughts, or their feelings, and derealization. The world feels kind of dreamlike or far away. There's a sort of unreal quality with intrusion of different self states. So, Melissa talked a lot during the conversation about this feeling of not me, where she was experiencing something, but it also felt like it was somebody else who was experiencing it. And also, there would be what are called partially dissociated intrusions, where these various self states would suddenly feel quite loud or pronounced in her experience. She even talked about characterizing them in different kinds of ways. She talked about the nice lady who handled the public speaking, which is something that she still doesn't like very much. And I really appreciate Melissa's willingness to have this conversation and her openness about her own experience, particularly given her mixed feelings about that kind of public speaking, which I thought she did phenomenally well during this conversation. And she also talked about the girl in the box and this almost kind of stick figure characterization of it. And then a more angry part, a more I think that she even characterized it as a boy, if I'm remembering correctly, that was more assertive or carried more of those kinds of feelings and emotions. In order to develop dissociative identity disorder, a person needs a combination of things. First, they need the ability to dissociate. This is an ability that is distributed in the population kind of along a normal distribution. So there are some people who are really extreme dissociators or have strong dissociative tendencies, and there are some people who barely dissociate at all. So to develop DID, you're probably going to be more out toward the tail of those big dissociators. Trauma is a necessary condition for dissociative identity disorder. And Lauren and Melissa did a really good job of explaining how this can develop in a kid. Kids have personification mechanisms. So a young kid might naturally say that the stuffed animal is mad and not me when expressing a feeling to their mom that they feel, they're not really supposed to communicate to their mom, but, my teddy bear is mad at you, that kind of a thing, right? And the line between reality and not reality is quite fuzzy. The Easter Bunny is real, Santa is real, Superman is real. And so you can see how a highly dissociative kid under repeated harm conditions could use that kind of ordinary tool to separate out the unbearable, awful stuff that is happening onto a kind of not me. And over time, that fragmentation becomes more significant and it becomes a real adaptation, a coping mechanism. And that's something that Melissa and Lauren also really hit over and over again during the conversation. This is an adaptive response to trauma. That's why people do this. And it's a very functional response. A lot of the time, it's what somebody has to do to protect themselves. It's normal for people to experience enormous amounts of shame related to DID and shame related to dissociation in general. I have some friends who are stronger dissociators, and they often feel quite embarrassed about it. This is a tough thing for somebody to manage, and popular presentations of DID, which are often really exaggerated and over the top, are not helping here because they can make it easier for a person to feel like something is deeply wrong with them or like their experience isn't even being captured by these kinds of dramatic presentations. We talked about the spectrum of PTSD and dissociation from classic PTSD all the way up to DID, and Lauren explained it a bit like being on a roller coaster. This was actually a metaphor that she got from somebody else, and I'm currently forgetting their name, but she said it during the conversation. So for classic PTSD, you're on the coaster, you're feeling the full adrenaline rush, the fear is happening to you. For the more dissociative form of PTSD, you're standing on the ground, watching yourself ride the coaster, and this is that detachment of depersonalization and derealization. Then all the way up to DID, it feels like somebody else is on the coaster and you're watching that person from far away. And you lose a sense of ownership and agency over the feelings, the memories, even the body of that person, to the point where it can feel like somebody else is living in your mind to an extent. And Melissa talked about that experience and how incongruous it was for her, how it didn't really make sense, how she kind of knew that this isn't the way a lot of people experience reality. And then that again can lead to that experience of, wow, something is deeply wrong with me, and the associated shame that comes with it. I asked Lauren what these differences look like for somebody in the brain, or if it's possible for us to tell the difference between classic PTSD, dissociative subtype, and then DID if you take a brain scan of somebody. And my understanding is that the answer is kind of, and at the very least, there are these different patterns of activation that we see in the brain. So there are these two important regions. The amygdala, which is a salience detector. It flags threats very quickly. And then the ventromedial prefrontal cortex. And this is an executive controller. And we can think about this more as being the brakes of the car. In classic PTSD, the amygdala fires, so you get that whole body activation. and the brakes aren't as prominent in the process. There might have some activation, but it's not as activated. In the dissociative subtype, it's the reverse. There is more prefrontal activity and less amygdala. So the brakes are on too tight. The person is more numb and detached. We really see that in these classic dissociative symptoms. So then in DID, the same person can show both the classic PTSD presentation and the more dissociative subtype presentation, depending on which self state they're in. We talked a bit about the long history of skepticism toward DID, which again, I think is fueled a little bit by some of these more fictionalized presentations of DID that you will see in movies or even on social media. But this goes all the way back in the field to Freud and him, wrestling with whether or not he thought this was essentially a real thing or not. I want to really emphasize that these days, inside of the field of psychology, there is no serious question about DID as a diagnosis. This is a real diagnosis. People really have this experience, and it is much more nuanced and complex than is typically presented. We talked a little bit about some of the misunderstandings out here related to dissociative identity disorder. I asked a question that came from Elizabeth about working with DID and whether or not people who were more dissociative, more susceptible to clinical influence than people who weren't. Milissa really emphasized that they are not more susceptible to false memory formation or something like that, but they are more susceptible to hypnotic suggestion because there's a lot of similarity between a hypnotic state and a dissociative state. Then we talked a bit about the difference between parts and self states and the difference between IFS-based approaches and their work with DID. Everybody has parts in an IFS sense, but everybody does not have intrusive, dissociative self states in a DID sense. We then talked a bit about what to do about all of this, including Melissa's personal experience doing long-term psychodynamically oriented work with a clinician who was able to help her with her own experiences and get to a place of greater integration. The clearest thing that I took from this conversation when it comes to treatment or working with your own experiences is that this is built on the relationship first and everything else second. With dissociation, a steady and consistent and well-paced approach to treatment in general and relationship building specifically is where most of the work is before you even get into exploring different experiences a person might had or helping them integrate their sense of self. Like you can't really get there until you have built this working foundation. That's very humanistic in terms of its tone and orientation, or very relational in nature. Good clinicians work slowly here, and they're going to help you stay in that range where you're neither totally slamming the gas or totally slamming the brakes or totally slamming them both at the same time, as the case might be. And they're going to help you through that experience so you can really titrate yourself. So when you're looking for a therapist who treats DID or dissociative conditions more broadly, you're looking for somebody that you think you can build that kind of relationship with, who you think is going to work at that kind of tempo, in that kind of speed. And sure, if they have additional certifications, additional terminology, trauma-informed, all of that good stuff, that can really help. But the thing to look for is that kind of relationship with, as Milissa said a couple of times, just a good clinician. Toward the end, we talked about what making a recovery looks like for a person. And I think the truth is that this really varies, and Lauren and Milissa kind of spoke to different ends of that, where Lauren talked about this difference between a kind of broader healing journey a person could go on and what they would describe as full recovery in a clinical sense. A person might still have these different self states, but feel like those self states are on the same team or rowing in the same direction, feel reconciled about that, feel good about that fundamentally. We may not describe that person as fully recovered clinically, but they've gotten to the place that feels good to them. Their symptoms are not bugging them in the course of their life, or they're mostly not bugging them in the course of their life, and everything is all very managed and manageable. That could be a great place that a person gets to. For somebody like Milissa, who went through this process and made what we might describe as a full recovery. She no longer has those self states as distinct things. There is this sense of integrated I at the center of all of it. I am that person and I'm also that person. And as I think it was Milissa who mentioned during the conversation that I have self states, I have parts, I have different aspects of myself that show up in different ways in different settings. I've got kind of podcast Forrest, and then I've got friend Forrest. That is a totally normal thing. There's not a darn thing wrong with that. We all do that to various degrees. And that's the state that a full recovery might look like for a person, where sure, there's still these different aspects of who I am, absolutely, but it all is me. Really appreciate Milissa and Lauren for joining me today. Again, particularly with Melissa's openness to speaking to her own experience. This is incredibly sensitive stuff. It is very difficult to talk about. And I think that kind of public-facing work that she's doing these days is really tremendous. There was a New York Times Magazine article where they spoke to Milissa related to DID, and I think that it's just really helped so many people understand these conditions better and get a better sense of who they are as people, get a better sense of what's possible for them, that these are real things that people experience. There are things we can do. We have good approaches to this stuff. And it is really possible to get to a place where you feel like you, pretty much from top to bottom, and you feel good about that you. Lauren's work on the cognitive neuroscience related to this is totally fascinating. If you are interested in reading studies that have fMRI scans or similar in them, you would absolutely love it. And they wanted to make sure that I directed people to the traumacontinuum.org website. That's trauma and then continuum, CONTINUUM.org for Trauma Continuum at Hill Center. It is a great website. There are a lot of resources there. Their resources are aimed at people who have been affected by psychological trauma, and they're trying to deliver person-centered, trauma-informed treatment, research, education, and advocacy to the public. Their work is fantastic. Please check it out if you're interested in this. If you made it this far and you somehow haven't subscribed to the podcast yet, wow, you should really subscribe to the podcast. It would help us out. You can do that on YouTube, on Spotify, on Apple, on wherever you listen to your podcasts. And you can also find us over at Patreon. It's patreon.com/beingwellpodcast. For the cost of just a couple of dollars a month, you can support the show and get a bunch of bonuses in return. You can also find my writing over at Substack. I'm writing a little bit more regularly these days. You can check that out. And more than anything else, the best thing you can do to support the show is leave a comment, leave a rating and a positive review, and hey, tell a friend about it. That is the best way that we got to reach new people. So, until next time, thanks so much for listening, and I'll talk to you soon.